Welcome back. Let's dive into some mood disorder case studies. Let's illustrate how all these considerations come together with a real world scenario involving a depressed patient. You're dispatched to a psychiatric emergency, possible suicide attempt for a middle aged male. On arrival, the scene is a bedroom in a private residence. The patient is sitting on the edge of his bed. Immediately, you notice he looks unwell. He's pale, his posture slumped, and he barely acknowledges your entrance. There are a couple of empty pill bottles on the floor. This is a big red flag for an overdose situation. Scene safety and general approach. The environment appears safe. It's a quiet home, family present, no weapons visible. As you approach, you speak calmly. Hello, I'm with EMS. Are you James? We're here to help. He mumbles a soft, yes, but doesn't make eye contact. One provider discreetly checks that there are no firearms or sharp objects around the immediate area and asks the wife, Ma'am, can you pick up those pill bottles and let me have them? And are there any other medications he might have taken? The wife is upset and says she's not sure. She just found him and the empty bottles. She hands you two bottles. One is an antidepressant, let's say sertraline, and the other was a pain medication, oxycodone, now empty. We quickly move into the primary assessment. The patient is conscious, breathing, but it's slow and shallow, 8 breaths a minute. His pulse is fast and thready, and blood pressure is low. These vitals suggest he may indeed be experiencing effects of a drug overdose, likely opioids given the signs and the empty oxycodone bottle. The EMS crew splits tasks. One provider starts supporting respirations by applying oxygen and preparing a bag valve mask to assist ventilations as needed, while the other provider prepares naloxone to reverse the opioid, intranasally for EMTs or IM or IV for ALS providers. Meanwhile, another provider engages the patient verbally, kneeling down to his eye level, speaking gently, Hey James, can you hear me? Can you tell me what you took so we know how to help you? The patient barely responds, just whispers, I I took them all. I'm sorry. He's clearly in despair. The provider responds in a comforting tone. I'm really glad we're here with you now. We're going to take care of you, okay? Try to take some slow breaths for me. The naloxone is administered, and within a minute or two, the patient's breathing improves and he becomes more alert. Often, they may become upset or even angry as withdrawal sets in. This patient starts sobbing and saying, I just want to die. Why did you save me? This is a heart wrenching moment. The provider responds empathetically. I know you're feeling like things are hopeless right now. I'm sorry you're hurting, but your life matters, and we want to keep you safe so things can get better. We're here with you. This kind of response acknowledges his pain, but also gently reinforces that his life has value and help is available. Now that the immediate medical threat, opioid overdose, is being managed, transport is imperative. The patient is placed on the stretcher. He's sobbing quietly but not combative. We do not need restraints because he's not trying to escape or harm us. He's actually compliant, albeit emotionally distraught. En route to the hospital, we continuously monitor his airway and breathing, in case another dose of naloxone is needed, and check vitals. At the same time, one provider continues to offer supportive words, maybe asking if he'd like us to contact someone or just listening if he speaks. He might alternate between silence and tearful statements like, I can't face anyone. We listen and reassure that right now the best thing is to get him care. We inform the receiving ER via radio that we have an intentional overdose with suicidal statements, so they can prepare mental health resources. On arrival, we hand off to the ED team, clearly stating, this is a 45-year-old male who attempted suicide by ingesting what appears to be a large quantity of oxycodone on top of his antidepressant. We administered 2 milligrams naloxone with good response. He has expressed that he wants to die. No harm to others indicated, no weapons present aside from the meds. Wife will bring the pill bottles. He's currently alert, emotional, denies any other substances taken besides what was in those bottles. This thorough handoff ensures the patient will get the necessary detox for the overdose and a proper psychiatric evaluation, likely an involuntary admission for safety. This scenario highlights key points. Ensuring medical issues overdose are addressed using a calm and caring approach with a suicidal patient, involving family for information and safety, like securing meds, and making sure the hospital is aware of the psychiatric risk. It shows how depression can present as a life-threatening emergency and how EMS roles go beyond just treating physical injuries. We are often the first link to life-saving mental health intervention. Now, for a scenario featuring a patient in a manic, agitated state. Imagine you're dispatched to a shopping center parking lot for a behavioral emergency. Reports indicate a woman in her 20s is acting erratically, and there are concerns for safety. Police have been called and are on scene when you arrive. On scene, you see a 27-year-old female pacing rapidly near the storefronts. Her appearance is striking. She's wearing very bright, mismatched clothes. For example, a thin nightgown over bright leggings and a big fur coat unbuttoned, even though it's a cold day and lightly raining. She doesn't seem to notice the weather at all. She's shouting things like, "I don't need any help. I'm on a mission to save the world," and then laughing, and then pointing at bystanders saying something about a conspiracy. People are standing at a distance looking concerned. The police officers are there, keeping a perimeter, but she hasn't physically hurt anyone yet. This is a classic unsafe scene unless handled carefully, so you coordinate with the officers. They say they suspect she's either on drugs or having a mental breakdown. One officer tried talking, but she got more agitated. As EMS, you decide to try your de escalation and rapport skills. You and your partner approach slowly, hands visible, one of you doing the talking. In a clear but non threatening voice, "Hi, my name is Megan. I'm a paramedic. I'm not a police officer. I'm here to help you and make sure you're okay. What's your name?" She stops pacing for a moment and looks at you warily. Let's say she identifies herself as Jessica, savior of the world, or something along those lines, which hints at a delusional grandiosity. She then immediately accuses, "You're with them, aren't you? You're trying to stop me." You respond gently, "I'm not against you, Jessica. I promise. I'm here because I'm concerned. You seem very upset, and I want to make sure you're not hurt or sick. May I come a little closer and check your pulse, just to see how you're doing?" It's a delicate dance. You're seeking permission to assess while also gauging her reaction. She allows you to step a bit closer, but as soon as you reach for her wrist to feel a pulse, she pulls away and starts ranting again about being on a mission. You decide not to force a hands on exam at this second. During this time, your partner has quietly signaled to turn off the ambulance lights and maybe asked an employee to turn off a flashing store sign that seemed to bother her. They've also encouraged the small crowd to disperse, reducing the audience that might be feeding her paranoia or embarrassment. Over about 10 minutes, you keep talking to Jessica. You use her name often, try to keep her engaged. "How are you feeling right now? When was the last time you slept or ate?" She's mostly non responsive to those questions, instead, giving disorganized answers. "I don't need sleep. I'm powered by the sun. The sun was talking to me last night." This confirms she's likely in a manic or psychotic state. She periodically laughs or claps her hands, then suddenly yells at a hallucinated figure. It's challenging. Sometimes she seems to listen to you calmly, other times she explodes, telling you not to come closer. Eventually, she suddenly dashes, trying to run past you toward the busy street. This is the breaking point. She's at immediate risk of being hit by traffic and possibly causing an accident. You, your partner, and the two officers manage to intercept and restrain her before she reaches the street. She fights fiercely, screaming and kicking. This confirms that without intervention, she's a danger to herself and others. The police help hold her, and as EMS, you quickly apply soft restraints to her wrists and ankles. Given her physical resistance and emotional state, a paramedic on your team administers an IM injection of a sedative, say midazolam or another sedative as per your protocol, to calm her down, with approval from medical control. It's worth noting, using chemical restraint is a serious step, but in this case justified by her uncontrollable behavior and risk. Within a few minutes, she begins to settle. Her shouting diminishes to mumbled complaints, and then she becomes drowsier while still conscious. Now you have a window to properly assess her. Vitals are taken. A quick BP pulse, which is high from all the exertion, may be signs of dehydration. There's no obvious trauma except a few scrapes from the scuffle. She denies taking drugs or alcohol, but we can't be sure without tests. You load her onto the stretcher, secured with straps and the soft restraints. Oxygen is given simply because sedatives can depress respirations a bit, and you want to keep her oxygenated. En route, she occasionally mumbles or suddenly tenses against the restraints, but generally the sedation is keeping her calm. You continuously monitor her airway, breathing, and circulation given the dual concerns of the sedative and her exhaustion after the struggle. At the hospital, you give a detailed report. "This is Jessica, 27-year-old female, acute behavioral emergency. On scene, she was extremely agitated, likely manic, yelling about saving the world, not sleeping, possible hallucinations or delusions of grandeur, no evidence of head trauma or known substance ingestion, though tox screen needed to rule out drugs. We had to physically and chemically restrain her for safety. She attempted to run into traffic. She received 5 milligrams midazolam intramuscularly about 10 minutes ago, now sedated but arousable. Vitals are heart rate 130 sinus tach, blood pressure 150/90, respiratory rate of 14 on oxygen, sat 98%. Blood glucose was 110 on scene. She's been combative, so we have her in 4-point soft restraints. We also mentioned that police are present and will do paperwork for involuntary psych hold due to her being a danger to herself and others. In the ED, the team will check for any medical issues like drug intoxication, electrolyte imbalances, etc. But assuming those are negative, she'll likely be diagnosed with an acute manic episode of bipolar disorder, possibly known history or first time presentation. She will be transferred to a psychiatric inpatient unit once medically cleared, where she can be started on appropriate medications, mood stabilizers, antipsychotics, and observed until stable. This scenario highlights how manic patients can pose unique challenges. They may be non-compliant, physically resistant, and require teamwork with law enforcement and possibly pharmacological intervention to secure safe transport. It underscores the importance of scene safety, patience in communication, and knowing when it's time to enforce control for the patient's safety. It's a dramatic example, but one that EMS providers do encounter. Thank you for your attention. If you have any questions, I'd be happy to discuss further or clarify anything. Stay safe out there. And remember that empathy and vigilance are your allies in managing mood disorder emergencies.